your heart into it. The HVC podcast centered around educating providers and staff about common clinical scenarios so that we can better treat our patients. Podcasts on this account are meant for educational purposes only and should not be used as a substitute for medical diagnoses or advice. If you have any clinical symptoms or medical questions, please consult a licensed healthcare provider.
So my name is Patel. I have the honor of being a cardiologist with HVC. And today I'll be talking about a topic that Dr. Kakar kind of touched on, lipoprotein A. So this is actually a very good tool in our tool belt and just an additional kind of data point that we can use to manage our patients and kind of risk stratify them and really try to reduce their atherosclerotic risk. I have no financial disclosures. So what is lipoprotein A? Lipoprotein A is basically like an LDL-like particle. So it's kind of like LDL, not exactly the same. Has a couple other components to it, apolipoprotein A and the apolipoprotein B100. It has a lipid core and then an outer shell. So one of my colleagues, Dr. Cherian, really wanted me to get into like the nitty gritty and the molecular structure, kind of go over the covalent bonds and all that. But I told him it was a kind of an overkill, so he's a little bit upset with me today. So you can find him outside. He will go over it with you. So lipoprotein A, majority of it is inherited. It's about 70 to 90% of it's inherited. And your number, you have one number, it's set by 5 years old. So really it's something you brought with you, really unaffected by your lifestyle choices, diet, exercise, smoking, all those things. So that is one of the things about it. And then prevalence, about 1 in 5 people have an elevated Lp(a). It's a very, very atherogenic, sticky particle. So that's really why it causes the risk that it does, heart attack, stroke, things like that. Very pro-inflammatory, thrombotic, things like that. So really an independent risk factor for heart disease, including myocardial infarction, stroke, aortic valve stenosis even, really an independent risk factor. Dr. Ahmad, emergency, where'd he go? That's an emergency. Dr. Maleka's on call. So Lp(a), it's a blood test. It's something I actually check. Dr. Kakar mentioned as well. I check almost now in every patient. The guidelines just came out, recommend at least a one-time check in all adults. So the normal levels, really less than 30 in the milligram setting, and then less than 75 in the nanomole setting. If your levels are more than 50 milligrams or 125 nanomoles, your risk level is much higher for atherosclerotic events. So it is a very, very good tool, as I said, in our practice. So some myths and facts about it. If my LDL is good, I don't have to worry about my Lp(a). Not true. LDL and lipoprotein A, as I said, are similar but not the same. You can have a normal LDL. As I said, the Lp(a) is an independent risk factor for atherosclerotic disease as well as aortic stenosis. So even if you have a normal LDL, checking your Lp(a), kind of identifying your risk is a good idea. Lp(a) does not affect my heart health. It does. As I said, it's an independent risk factor for heart disease, stroke, myocardial infarction, and such. If I don't have any symptoms, my Lp(a) may be fine. Just like a couple other things that we check, not true, right? Asymptomatic things like blood pressure. Your blood pressure could be high, you could be asymptomatic. So really, every adult tested at least once in their lifetime, at least per the recent guidelines, which is a very good idea. If you're a family history of heart disease, family history of high Lp(a), again, a good idea to get it tested. Lp(a) not passed down in families, that's a myth. We know that 70 to 90% of it is inherited. And then it doesn't affect everyone else the same, including me. Some factors, as I said, can change your levels, but usually it is a kind of that set number that you get. Certain things that may affect it, pregnancy, menopause, and thyroid disease, kidney disease, are a couple other things that can affect it. So what do we do about it? Lifestyle modifications. We went into this extensively in the earlier talks, but eating a healthy diet, exercising, not smoking, and good sleep, weight management, all those things, managing your risk factors, diabetes, goal A1C, goal lipids, hypertension, be healthy as this guy. That's actually Dr. Kim with somebody else's face on there. So 2026 guidelines, not really going to harp on this too much. The handout is perfect. Dr. Kakar's talk was great. But universal screening, which I'm very, very happy about this. All adults, at least one time in their lifetime, should have their Lp(a) checked, kind of stratify their risk, go over the LDL goals, less than 100, less than 70, less than 55, depending on your risk level, and risk reduction, all the things that we know what to do about it. So therapy, basically, the LDL goal, that's one of the main things. Apolipoprotein B as well. I also check that in a lot of my patients who have at least intermediate to high risk of heart disease. Statins are, a therapy that we use for LDL goals. The verdict is still out. Does it really lower your Lp(a) levels? And some sources say it does, some sources say it doesn't. But independent of lowering Lp(a) levels, we know it does lower your cardiovascular risk by lowering the LDL and your apolipoprotein B. Niacin's known to reduce Lp(a) levels as much as 40%. It lowers your LDL a little bit, increases your HDL. However, really, it doesn't implicate a lower risk of cardiovascular disease alone by lowering your Lp(a) level. Of course, it does by lowering your LDL. And then the big thing with it, there are some interactions with statins. PCSK9 inhibitors, Repatha and Praluent, 20 to 30% reduction in your Lp(a), and it implicates a lower cardiovascular risk. So that's a very, very good therapy we have. Apheresis, kind of not very commonly done, but it definitely lowers your Lp(a) levels 50 to 85%, and lowers your LDL levels as well, 60 to 80%, especially in patients with functional familial hyperlipidemia. It's a very good tool. And then if you have coronary artery disease, LDL more than 100, and your Lp(a) is more than 60 milligrams per deciliter, that may be a consideration. And then the last kind of medications that are on the market, 20% reduction by Leqvio, inclisiran. So just a little slide showing all the different kinds of therapies and kind of the reduction in the Lp(a) levels, and does it reduce your cardiovascular risk or does it not? There are certain therapies in trials currently that they're working on lowering Lp(a) levels. So I'm kind of really looking forward to that. It's kind of a topic that hits close to home. My Lp(a), I made the mistake of checking, is high. So I really like my ice cream, so that may be a problem. But I'm definitely tuned into these trials and kind of seeing how these medications come out, these therapies, and see how they reduce your Lp(a) levels. The big question will be, even by lowering your levels, does it implicate a lower risk of cardiovascular disease? So I'm going to stay tuned in for that. And then in summary, pretty quick, summary, the Lp(a) is genetically determined. It's kind of something you brought with you. Really very little effect on it by lifestyle choices, diet, exercise, smoking, those kind of things. It's an independent risk factor for disease, myocardial infarction, stroke, and aortic valve stenosis. Different medications have different lowering effects, and then as it stands out in reducing your cardiovascular risk. Experimental therapies are in progress, so we'll be staying in tune for that. And then by the new guideline recommendations, all adults should have it checked at least once in their lifetime. And then your Lp(a) level more than 125 nanomoles or more than 50 milligrams, that tells you a much higher risk. For patients that have a high Lp(a), I do give them this website, they can go and learn about it and kind of show their relatives, because it is something that should be tested. If you have a high Lp(a), your family should be tested as well. Perfect. Any questions? Yes.
Is there anything research-wise about aspirin therapy for folks who have Lp(a)?
I think not necessarily as it pertains directly to Lp(a), but overall your risk reduction, your moderate to high risk patients that you have, they should be on aspirin. That can help in other ways, reduce your cardiovascular risk, but not as it directly impacts Lp(a) from what I know. All right. Thank you, guys.
Thanks for listening. Tune in next time for another cardiology-focused episode.